things to point out here. First, these two cases make the incredibly important point that class matters from the very outset of an illness, like a heart attack, or any other kind of disease. That is, rich and poor have different kinds of facilities available to them. They receive different quality of treatment, different kinds of doctors. They have different levels of social capital to acquire specialists or experts. They have different relationships with healthcare providers. And perhaps most importantly, they have different treatment schedules, with the wealthy typically getting treated faster and more thoroughly than the poor. This is particularly true in the US. But also, class matters in shaping lifestyle changes once an illness sets in. The wealthy are often in a much better position to positively change their lifestyles. They may cut down on stress, they may cut down on work responsibilities, they make their lives more comfortable for themselves, they might eat healthier, and they may often do things that require money, like gyms, trainers, yoga classes, etc. The poor are often less able to do that. They're less able to integrate healthy lifestyles into their daily routine. And as a consequence, they're more likely to suffer secondary health problems that then become themselves major problems, such as like diabetes. Also, the poor may have mounting health bills. They may have to take time off from employment, which creates even new stressors. And we just discussed how stress can have a very detrimental effect on health over time. So, class is incredibly important, and it works in a number of ways to shape how one bears through illness and ultimately rates of mortality. There are other ways, though, in which class also matters. And now I want to move the discussion a bit to thinking about the connection between environment and health. Environment and health. Nova Scotia. So, Nova Scotia and throughout Canada, we have a really interesting example of how environmental hazards are correlated with class, which are then correlated with rates of disease. In part, what you have in the case of Nova Scotia is really a function of class. Class position varies inversely with the rate of cigarette smoking, access to medical care, knowledge about how to prevent cancer. In other words, the poorer you are, the more likely you are to smoke, and the less likely you are to have knowledge about cancer prevention. Breton County, as this slide shows, has the highest county cancer rate in Nova Scotia. It's partly because Cape Breton County is the 5th poorest of Nova Scotia's 18 counties. And also partly because Sydney, which is located in Cape Breton, was home to a large steel mill for a century. Now this steel mill deposited industrial waste and dumped it into the tar ponds in Sydney, which is a huge site polluted to a depth of 24 meters with cancer-causing heavy metals and arsenic. Now sludge from those tar ponds oozed into people's basements and into the water table. It oozed into vegetable gardens, and it runs in open streams where children play. So Sydney also has the highest community cancer rate, big surprise. And the people who live around this area are typically the poorest within Sydney. And they also have the highest neighborhood rates of cancer. And cancer isn't the only problem these people have. They also have terrible skin ailments, birth defects are usually high, they have respiratory problems, they have diseases of the nervous system, and other kinds of medical conditions that are unusually common right around where the tar pools are. So here we have a really striking example of how class exposes people to environmental conditions that cause illness and death. As that New York Times video made clear, lifestyle factors are also important factors in shaping health. Smoking cigarettes, excessive use of alcohol and drugs, poor diet, lack of exercise. These are among the chief lifestyle factors associated with poor health and premature death. Now I know these are the kinds of lifestyle factors that most of you here practice on a regular basis, but hopefully by the time you graduate university you'll knock it off and you'll take better care of your health. Other things, other sort of odd things that you may not have thought about that affect health. How about this one? Social isolation. Social isolation. In fact, there's increasing research that shows the more socially isolated one is, the more likely one is to experience illness and premature death. So social isolation has been shown across studies to affect one's chances of becoming ill and dying prematurely. And here are some examples. Unmarried people have a greater chance of dying prematurely than the married. At any age, the death of a spouse increases one's chance of dying, while remarrying decreases one's chance of dying. And this you may have seen or heard of in your family or the family of friends. You've got a couple that's been living together for a long period of time, maybe your grandparents. Grandma kicks the bucket one day, right? And within like 6 months, grandpa joints are in heaven, right? So it seems like, again, when people feel a sudden degree of social isolation, for instance, the death of a spouse after a long marriage, rates of disease and death follow and increase. Now, social isolation has its own particular social patterning. It's a particularly big problem among the elderly. Elderly people who retire or who lose a spouse, as we just said, and lose their friends. If they can't rely on family members for social support, such people are often prone to fall into a state of depression that then in turn contributes to ill health. So social isolation, keep that in mind. Another factor that sociologists study, which would be less surprising to you, is the public health and healthcare system. The state of a nation's health depends a lot on public health care. The public health system is composed of often government programs that ensure things like clean drinking water, basic sewage, sanitation services, inoculations against infections and disease. A lot of things that we take for granted here in our first world country of Canada. Now, the absence of a public health system is associated, conversely, with high rates of disease and low life expectancy. AIDS is an example that makes this very point. So AIDS is the leading cause of death in the poverty-stricken part of Africa, south of the Sahara Desert. This figure tells us that in 2009, 5% of sub-Saharan Africans, which is 22.5 million people, were living with HIV/AIDS. In contrast, look to the north. 0.6% of North Americans and 0.3% of Western Europeans are living with HIV/AIDS. So this means that AIDS is more than 8 times more common in sub-Saharan Africa than in North America, and nearly 17 times more common than in Western Europe. Here's the thing, despite the fact that HIV/AIDS is so much more prevalent in sub-Saharan Africa, spending on research and treatment is concentrated overwhelmingly in the rich countries of North America and Western Europe, not in sub-Saharan Africa. So you see how the case of HIV/AIDS illustrates in striking detail how global inequality influences the exposure of people to different health risks. And so here we're talking about class, in a sense, but at the global level. And we're looking at the stratified global system and the ways in which certain countries, which are on the poorer end of that spectrum, or the poorer end of that system, also have poorer health outcomes. just like individuals in a given country. Okay, turning to Rudolf Virchow. You recall good old Rudolph, beautifully dressed, very impressed. Recall that Virchow said that once industrialized countries started to develop their public health systems, that there would be great improvements in health, and indeed he was right. The problem is that what was possible in North America and Western Europe maybe 150 years ago is not really as possible or plausible in many of the developing countries today. Most of us, as an example, take clean water for granted. In contrast, more than 1 billion of the world's 6 billion people do not have access to clean water. And we know that when sanitation is poor, health often follows, and is also poor. So the point in general is that national wealth is critical for shaping health outcomes in a population. When national wealth increases, so does national health become better, and more money can be spent on things like sanitation and other preventative measures. Another interesting thing to note about wealth and global economies. It turns out that it's not just a country's average level of wealth that accounts for how wealthy its citizens are. In fact, the level of inequality, that is the gap between the rich and the poor, the level of inequality within a society has a major impact on the health of its citizens. So let me say this again. The level of inequality within a society has a major impact on the health of its citizens. So that countries that have a high level of inequality tend to have less healthy citizens. Countries with low levels of inequality tend to have better health outcomes. You can see this represented here in life expectancy. So comparing the USA and Canada is instructive here and makes the point. Canadians live on average 2 years longer than Americans. But Canadian GNP per capita is far lower than that of the US. The US spends, in fact, far more on health care than any other country in the world, and yet, on average, is less healthy than all of the populations of other rich countries. So how do you explain that? Well, part of the reason is that the gap between rich and poor is greatest in the United States. It's greater than in Canada, greater than in Japan, Sweden, France, and other fairly wealthy countries. So what we find here is that the higher the level of inequality in a country, the more unhealthy its population is. So the US contains a high percentage of poor people than other rich countries, higher than many other countries, and in turn has average levels of health that are lower. So what do we want to take away from this? Here's a slide that recaps what we just said. Why are the poor more likely to be unhealthy and to die younger than those who are not poor? One reason is that they are more likely than others to be exposed to environmental factors, such as industrial pollution. A second reason relates to lifestyle factors. The poor tend to have more unhealthy lifestyles. They have less knowledge about healthy lifestyles. They're less likely to know what constitutes a nutritious diet, as an example. And they sometimes have a harder time to change those lifestyles. A third reason, as the slide tells you, is that the poor often can't afford adequate or sometimes even minimal health care. And this is especially true in countries without government-sponsored universal health care, like Canada. So poor people have less access than the well-to-do to doctors and hospitals and services. They also tend to have less knowledge about healthy lifestyles. Moreover, the poor are disproportionately affected by bad environmental conditions. They're not as able to move away from a place that may have a bad environmental condition, and they're less able to choose neighborhoods that are more desirable. Okay, moving on from class, I want to talk now about health, illness, and gender. Actually, there's some really interesting ways in which gender and health work together. And medical sociology tends to look across the board to find some of these interesting connections between gender, health, and medicine. Here's something interesting. In terms of medical research itself, there has been a huge gender bias in what actually gets researched in medicine. So historically, there's been much more research on men's diseases like cardiac arrest or prostate cancer than on women's diseases like breast cancer. Similarly, medical research is only recently beginning to look at the particular effects that medications have on women as opposed to men. The idea being that women's bodies on average may not be biologically the same as men's, and therefore will respond differently to medication. So this is an idea which seems to be so self-evident, and yet we haven't seen a comparable level of medical research looking into these differences. There are also gender differences that exist in medical treatment. So for example, women undergo fewer kidney transplants, they undergo fewer cardiac procedures, and a host of other treatments that are more common with men. Now, because women live longer than men on average, they experience greater lifetime risk of disability and chronic illness, and they have a greater need for long-term care. Yet much more is spent on men's than women's health care in some countries, like the US. So you'll be happy to know, as Canadians, that in contrast, Canadian health care actually spends about equally for women and men, including things related to expenditures related to childbirth. However, that's not to say that gender still isn't a factor in health in Canada. Here's an interesting statistic to think about. There are 30% more poor women than poor men in Canada. 30% more poor women than poor men in Canada. And we know what poverty does in terms of ill health. So we can expect that women's poorer economic standing on the whole will be negatively reflected in their health status for all the reasons that we just mentioned. And statistics tend to bear that out. So yes, women do live longer. In most parts of the world, women live longer. But nevertheless, gender inequalities have a negative impact on the quality of a woman's life, even as she lives longer. Okay, here are a few other things that you may not have considered in terms of health, well-being, and the body. And I want to turn specifically to things that I'm sure you haven't thought of, like, as an example, height. So height is a really good starting point for this discussion. Why? Well, we often think of height as being determined by our genes, right? Determined by your family's height, much like your eye color or your hair color. Well, a couple things to talk about with respect to that. First, there's a really interesting study conducted a few years ago. 4 people, exactly the same height. They're all 5'9". So 4 people, 5'9", with roughly similar appearances, were introduced to a group of students like yourself. Now, the first person was introduced as a fellow undergraduate student. The second 5'9" person was introduced as a graduate student. The third, a professor, and the fourth, the president of the university. Now, the students were then asked, the 4 people left the room, and the students were then asked to assign one of those statuses to the people who were all 5'9", right? Which person was the undergraduate, which one was the graduate student, which one was the professor, and which one was the president of the university. And what do you think they found? Nothing systematic. About 25% of the undergraduate students named person A as the professor, about 25% labeled person B, about 25% labeled person C, about 25% labeled person D as that category. So there were no systematic attributions based on the people who were all the same height. Now, 4 more people were ushered in. They roughly looked the same. The only difference is that one person was 5'2", one person was 5'6", one person was 5'10", and the fourth person was 6'1". They asked the undergraduate students the same question. Which of these 4 people is a fellow student? Which is a graduate student? Which is a professor? And which is the president of the university? And what do you think that they said? Well, what they said was, in overwhelming numbers, that the president of the university was the 6'1" person. The professor was the second in height. The graduate student was the 3rd tallest, and the undergraduate student was the 4th tallest. So apparently, physical stature, one's height, tends to be related in our minds to social stature. And height, as a consequence, has a huge effect on life outcomes. So here are a few examples. Taller people, on average, earn considerably more money throughout their lives than shorter people. With every inch, you can expect to make $789 more a year in pay. With every inch. Now, remember what I just said about income and health. You see where this is going? You see where this is going? Skin tone is also related to income and well-being. Studies in the U.S. have shown that lighter-skinned black women have, on average, higher self-esteem than black women with darker skin tone. Black men with lighter skin and more European facial features have been found to have higher socioeconomic status than black men with darker skin and more traditionally African features. So these findings suggest that the way the body is assigned social value has real impact on the people who inhabit these bodies. So let me get back to height for a second. You might ask, why are some people tall in the first place? Are they just morally superior to short people? How does this work? Well, what's interesting here are that different populations make an interesting point. There are a complex series of social factors, believe it or not, that determine the average height of any population. So not just genetic factors, but social factors. In fact, class has a huge impact on height. And here's a figure that shows you some of the social causes and consequences of height in the human population. Okay, what does this slide show us? It shows that, again, some of the main social causes of height and then the consequences. So for purposes of illustration, consider the impact of family income on stature. That's highlighted in red. Average family income is the single most important determinant of the quality of one's diet, especially protein consumption. The higher one's family income, usually the higher quality the diet, the more protein that's eaten. In turn, the quality of one's diet during childhood strongly influences one's stature. So on average, North Americans born today are taller than North Americans born a century ago. Why? Not because of genetic factors, but simply because people today, on average, have more access to protein-rich diets. North American-born children today are taller than their parents when their parents are born abroad. for the same reasons. Now, I can speak about this from personal experience. Maybe some of you can too. I'm considered on the short end of the spectrum.
How tall are you?
I'm about 5'8" on my tallest day. My paternal grandparents, however, were really short. They were born in Germany. They experienced pretty harsh economic conditions. My grandfather stands at 5'3", and my grandmother is 4'11". She's like a little cute bulldog. My maternal grandparents were also born in Central Europe, and they're only a wee bit taller. So if genetic factors were the primary cause of one's height, I probably couldn't even teach this class because I wouldn't be able to see over the podium, right? Rather, the difference is that while I was raised on milk and meat and other high protein food items, my grandparents from Germany did not have those luxuries. They were lucky to have bread and some basic soup. So because I enjoyed a much better diet as a child, I reached a much taller height than my grandparents did, genetics aside. So forgetting about my case, this correlation between family income and average height is very strong across many countries. But the story doesn't end there. Within countries, there's also a correlation between height and class position. On average, the higher one's class position, the greater one's height. Now, today, these differences in height are smaller than they were a century ago because higher protein diets are available to the masses more often than they were 100 years ago. But even today, members of upper classes are on average taller than members of the middle classes, who are in turn taller than members of the working classes. Now, the one set of countries that are the exception to this are Scandinavian countries,